Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential.
It is a great day today for a podcast. We have an awesome guest. We have Girish Sabari. He is the Executive Director of Triumph Remote Monitoring and Angel Valley Hospice. We are so honored to have you here. So just a little bit about you, Girish. You have worked in business and strategic roles within the community-based physicians and hospitals for 27 years. For 10 years, you've been involved with the Dallas community, working in hospice, home health, and telemonitoring. You are currently focusing your attention on preventive healthcare and wellness through telemonitoring. And we're so excited to have you here. Brian, great to have you too.
Thanks, Joe. Yeah, we're definitely excited to have this conversation. I'm familiar with this remote patient monitoring, because we've looked at this for several years, and there's always been limitations, which we can kind of get into, but you guys seem to have solved a lot of those issues. So before we get into what RPM is and remote patient monitoring, can you kind of give the backstory on how you got started in hospice and then also the remote patient monitoring?
Sure. So thank you, Joe and Brian, for having me. It's such a pleasure and honor to be here with you today. Yes, I think I've been doing healthcare for almost 27 years, and I think that's very much part of me now. We all have seen, the transitional phase of healthcare over the years. Especially last 10 years have been very exciting, journey. I would say more, just not exciting, more meaningful, especially, having the opportunity to do hospice. Mm-hmm. So I've been doing hospice in DFW for a little over 10 years, especially, with Angel Valley Hospice, which is kind of my own baby that we started 4 years ago. The objective was very clear. We wanted to have patients and families have a very personalized experience. And the team and the philosophy of what we believe in the company is, this doesn't have to be a tough and sad experience. Mm-hmm. Make it more meaningful, get them the help what they need. And, it's most of the time it is, I always say 40%, it is 60% of patient care. The remaining 40 is working with the families, mm-hmm. right? But I think having said that, right in the middle of COVID, everybody knows what happened in COVID. We all got into pretty much a remote operation mode, and that's when I realized, we are definitely in need of some more system and support system mm-hmm. to work alongside the healthcare system, broadly speaking. Mm-hmm. That's when it's been a perfect timing for me personally to jump on this opportunity, which we're definitely going to talk more. It is remote patient monitoring, which I think the Medicare introduced in 2019.
Yeah, so we both started our companies around the same time, which is interesting. Yeah, in the middle of COVID, and so if you remember back in those days, we were all locked out of buildings, hospitals, rehab hospitals, assisted living, and so it was hard as home health and hospice providers to actually access your patients for a period of time. And so it sounds like because of that, there was this necessity this need, we've got to be able to monitor our patients somehow. And if even our hospice nurses are being prevented from going and seeing these people, it sounds like that's where this idea for Triumph came about.
Absolutely.
Yeah.
There was an opportunity to connect, the gap, basically bridge the gap between the physician and the patients. I think we saw the opportunity. We definitely want to, be a player in that space. Mm-hmm. That's really what got us started.
Yeah. So probably started off as a need for how do we keep tabs on our current patients on the hospice side of it. But as you start to kind of come out of the COVID era, then you start to realize, okay, this is a much broader application here. So things like keeping patients out of the hospital, there's a big return to acute thing that's been around for a few years where hospitals get dinged. I think you have some stats mm-hmm. on what those penalties look like. So there's been a big focus. And one of the challenges, because I've interviewed several of these companies before for own home health, and one of the big challenges that you guys have solved, because Correct. It's done through a different means now, was when I was working with them or looking to contract with them, because I believe in this too, like there needs to be a way way to monitor longer term these vitals, because you're trying to get a glimpse of what's happening to a patient before a major catastrophic event happens, right? And so a lot of times these show up in vital signs, or we've talked about the sixth vital sign being gait speed, but they show up in some manner that we can track, that we can measure. And if you can catch them before the major event happens, then we avoid the falls or the UTIs or at least intervene earlier before they go in like full-blown sepsis or whatever. And so I really like the idea of remote patient monitoring, but the downside of who I had talked to in years past has always been, it's been done through the home health. And so when you ask them, what's the average length of time that a patient has access to these this product or these equipment that goes in the home, they'll tell you roughly 40 days. And it's like across the board, all the companies I talk to, roughly in that 40-day range. Why? Because it gets them past the hospital penalty mark. Yeah. And so you think about it from a patient's perspective or a family's perspective, the challenge I could never get past was, okay, so I'm going to train a patient and a family on this RPM stuff, this equipment, and how to access the app or whatever this software looked like. And then 40 days later, once you're used to using this, now I'm going to rip it out. We're going to have to retrain you on something entirely new. It just never seemed to fit for me doing it from home health. So I was fascinated when Joe introduced you to me. I had no idea that this actually existed where you could do it apart from the home health, where it could actually be a longer term system to help monitor those. So can you tell us kind of what that looks like? Like, what do you monitor? Who does it through? Who's it done through? That kind of stuff.
Sure. I think Medicare has made it very simple. And as we were talking before the show, the whole objective why they're even doing this is the common objective is bring down the readmission rates. And we all know that's unfortunately the pit hole that the Medicare is dealing with. Mm-hmm. So at the same time, they have simplified the whole process. So the key drivers are the primary care doctors. So we get to work with them as an extension of their team, as a third-party agency. And just to answer your question, why Medicare is doing, because there's a huge gap in our healthcare system between one visit to another visit. So let's say on an average patient visit is 3 or 4 times a year, right? And I think we all know with a lot of comorbidities and other chronic conditions, it's very difficult to manage and stay on top of their chronic conditions with just 3 or 4 visits.
They can change overnight.
Absolutely. And the program is designed such a way that doctor gets to monitor this through an extra set of eyes.
Yep.
That way he is still connected through the nurses who represents, companies like Triumph, for example. Okay. There are 2 aspects to the telemonitoring, broadly speaking. One is chronic care management, which is CCM. And then, of course, the remote patient monitoring, which we call it RPM. So CCM is purely clinical interaction. Again, everything is done remotely over a phone call. We don't change anything. The whole goal is reinforce everything what the physician wants the patients to follow.
Yep.
The role is simply to make sure, okay, the patient is following the medication, if there's any change of conditions, how the vitals are. So, the idea is not to change anything, but reinforce everything what the physician wants to do.
Yep.
And that call happens at least 1 call every month.
Okay.
And it is designed such a way, though the physician is not involved on a day-to-day basis, the moment if there is anything that he needs to be, basically we need to escalate, then the physician come in and he's going to be in touch with the patient, maybe call for a visit or address the issue before it hits the roof. So that's why, that's the whole objective of CCM. Now, talking about RPM, this is where the device is involved. We use devices which has data capabilities. So the program expects patients to, actively participate. That's why we spend a little time to educate them how this is going to benefit in managing the overall health and, of course, the chronic condition, right?
Yep.
So it's as simple as taking a reading at home. And then, of course, we have a team that monitors. Just in case they're not on top of the reading, then we have team, the back end, who will remind them to do it. Yep. And, of course, the physicians will set the parameters at what point they want to be notified. Let's say if somebody has a reading, let's say 160, 120, obviously the physician want to be notified. And then he gets involved and he's take it from there. So we're not a solution for any emergency care, but the whole goal is how we can actively, stay in touch with the patients bridge the gap.
We usually teach this on like a red light, like a stoplight concept, where, everything in our bodies it's not binary, like yes or no. It's ranges, right? There's a upper end of a normal range. There's a lower end of a normal range. And then there's the yellow zone, which is like the cautionary side, which is, hey, you probably need to do something to get it back in the green zone. And then once it flips to the red zone, this is like a 911 call.
Yes.
So where you guys are trying to keep them is, if they start to realize they're moving into those yellow zones, a little too high, a little too low, how do we interact or intervene to get them back? Or sometimes it's the physician getting involved, but you're trying to spot them as things start to trend either too high or too low to get them back to that kind of happy, safe green zone.
Right. I love this. I know my father-in-law had to check his blood pressure every day, and he had a little bitty notebook. He checked it for years in this one little notebook. But just talking about readmissions and people discharged from the hospital, they're put on a home health, they are put on hospice or assigned to a care manager. We want to keep them out of the hospital. And last year, Medicare readmissions cost Medicare $26 billion. And so I know with this new administration coming up and wanting to cut costs, a lot of unnecessary costs, to me, this program is something that every doctor and patient relationship should have on hand. I think it's so awesome. So I know you do daily weights, blood pressure. What else services on that?
So right now we have 4 modalities, blood pressure check, blood sugar, pulse ox, and the weight scale. The beauty is, since we've been doing this for the last 4 years, the nurses who makes those calls, they eventually land up building a good relationship with the patients, and they kind of begin to work together. And of course, doctor is the last piece, and he's definitely put together in this whole program so effectively. But end of the day, you see that how the patients kind of feel that, okay, they are in trusted hands. They have somebody that they can call and address their issues rather than waiting for a problem to get off the hook. So honestly, this program is very meaningful, and I think it connects the whole system. I see why Medicare love it, because the gap is very minimized. So
yeah, a lot of these chronic illnesses are punctuated with exacerbations that happen, throughout the year or throughout, a few years or whatever. And so if you can minimize the number of exacerbations that lead to hospitals and more costly intervention, this is where Medicare saves money, by actually reimbursing for some of this stuff. They can actually save money on the whole, because we're avoiding some of the larger, because I think you said the average hospitalization cost now is roughly $15,000. Is that right?
The average readmission is $15,000.
Okay. Yeah.
Yeah, and you multiply that by a lot of patients.
Yeah, and they're also saying about 2/3. This is what CMS is calculating or theorizing. About 2/3 of all hospital readmissions are considered preventable. Mm-hmm. So again, if we can invest in some technologies or some ways to be a little more proactive, which that's our thing, is how do we the reason why healthcare is expensive, well, part of the reason why healthcare is expensive is because it is reactive. Like, we're waiting for the catastrophe to happen before we intervene. And so that's where things like this remote patient monitoring component can catch things early on. We were talking about before, I had a patient experience just here recently where on a couple of vital signs, she wasn't feeling it yet. So she looked fairly normal. I could tell she was a little bit off from what I'm used to seeing from her, but her blood pressure was fairly normal. Her heart rate was a little bit elevated, and then her temperature for her was about a degree up. And so instantly called the doctor, said, hey, this is what I'm seeing. So again, these are small changes, but I've known her for a while, so I kind of know what her normal is. And sure enough, full-blown bladder infection was what was brewing for her. And so they got her started on antibiotics really fast. And so this is where these kind of things can be really helpful, because what did you also do? You tell me, you said the number one cause for hospitalization is what?
Hospital readmission is sepsis.
Right. Often brought on by urinary tract and bladder infections. And so yours truly, although I'm not remote patient monitoring, but because I was there, this just goes to explain a great scenario of, if you can catch a lot of these things as they're starting before they're full-blown sepsis, then we can save a lot of cost.
And to me too, it would be an advantage to the doctors, because they only have, I know my son's a physician, they only have X amount of minutes with these patients. And so if they have a baseline and know, okay, her blood pressure is going great, we don't need to really address this today.
Yeah.
Just, hey, you're taking your medicine, your blood pressure looks good. Let's move on. What else is going on? Because these people with chronic disease processes, 4 or 5 things going on, the doctor doesn't have time to discuss every disease process that patient might have. So I think that is a win for physicians, just to keep them in the loop on what's going on at home.
Absolutely. And I think the data that we are capturing is available for the doctors at 24 hours. And, they're not now looking at just the monthly data. They get to see a data over a year. So I think it really helps them with their, how they want to manage the condition.
Mm-hmm. Yeah, you guys are familiar with the term white coat syndrome? Have you heard this before? So for audience or who's not familiar with this, this term implies that there's a certain percentage of patients. It depends on what you read. We're going to say it's roughly 20% is whatever the number I remember. I could be way off, but roughly 20% have what they call white coat syndrome. I have it, not for doctors, but I have it for dentists. And so I know trauma. But when they go see the doctor or the dentist or anybody in a white coat, we don't wear his white coats as often anymore. But when they go see a physician or a dentist, their blood pressure goes up. Well, if you're only seeing that doctor, 2 or 3 times out of the year, and every time you go, your blood pressure's up, what are they doing? You go
put you on blood pressure.
Put you on blood pressure medication.
Absolutely.
Yes. And then what happens when you go home and you're normal?
Yeah.
Well, in an older patient, you actually are dropping their blood pressure in a lot of cases way too low. So this is one of the most common things that I see as a PT with fall risk is too low blood pressure. And so it's a consequence of having data being pulled from a physician's practice where, let's face it, they're busy practices. They're probably not sitting for the ideal 15 minutes before taking a blood pressure, right? So it's going to be elevated anyway because they just walk back in the room and the med tech's or the MA is going to be taking blood pressure right then and there. And so it's going to be a little bit elevated in some cases or because of white coat syndrome. And then when they go home, the blood pressure is normal. Now they've added a blood pressure med that drops them too low. And now they're starting to get dizziness and having falls. And so having, again, daily, it doesn't even have to be daily in some of these cases, but a few times a week, blood pressure readings in these cases can certainly start to show the physicians, hey, this is where the trend is for blood pressure. And do we actually need to intervene with blood pressure medications, or is there something else that we need to do, or is it just normal?
I think too, the adult child who worries about mom or dad living alone, it makes that patient accountable too, that, oops, I better weigh myself every day. I better take my medicine. I've got to check my blood pressure. The kids will know, the doctor will know if they're not being compliant and taking the medication correctly.
Right.
So that's another win-win with this program. Absolutely.
I think every piece in this healthcare model, they feel they're more connected with the patient, even if it is remotely, and of course they have more data to work with.
Right. I can't imagine so just an analogy, if you were driving on a car that had the check engine light on and you just know, like, it's a buggy light, right? We're probably not driving around with that check engine light, on all the time. Like, there's a reason we have a dashboard that has all these alerts. This is just an alert for an older body.
My husband, it drives him crazy because I'll have some kind of a
okay, so not you, but those are
it's not me. It's like, why have you not told me?
But my point is, this is the dashboard alert system for an older body that alerts us to things before, hey, pull over, right? Or call the doctor, or the nurse is going to call you before we have this big event that happens. Mm-hmm. Big blowout.
And it also, another statistic is the highest readmission rates are seniors over 90 years old.
Which isn't surprising.
I know.
Yeah, they're more frail.
And a lot of them, though, they want to stay independent, but they really can't be alone anymore. I have a client right now that needs a caregiver with her, and she is just stubborn and doesn't want it. But, that's what keeps you out of the hospital. They will make sure you're eating right. They'll make sure you're taking your meds. You're doing your monitoring, stepping on that scale or whatever. Just a little fun fact. What hospital in the United States has the most ER visits?
I only know this because you quizzed us before. beforehand.
So what's the answer, Brian?
Parkland.
That is right. Parkland, right here in Dallas, Texas. And I had the privilege of working at Parkland for 3 weeks.
Oh,
it just was not for me. But it was crazy over there. It was crazy. I had drug addicts. I had prisoners. It was crazy. It's my most short-lived job, but I went to hospice after that.
Yeah. So Girish, on the RPM side, there's obviously physician practices that you guys are working with who will recommend this to some of their patients. can patients ask for this themselves? Can they go to their primary care doctor and say, hey, I watched Girish, this sounds fascinating, I want to be able to monitor this and have a nurse who's kind of looking at this and making sure that things are trending appropriately? Could they reach out to y'all and have you guys help to set that up? Can we, I guess my question is, I know it can be initiated, services like this, through the physician. Can a patient or a family member also initiate services as well?
A good question. I think we need to understand this program is just 4 years old. So still, picking up its familiarity and popularity, I would say, especially among the physician community.
Sure.
I think there's still a gap, but it's definitely picking up pace. A lot of physicians are now confidently getting into this program.
Okay.
In fact, if you see CMS is encouraging physicians to actively participate. Now, just to address your question, if I think a lot of patients and families are also getting educated on the telemonitoring and the benefits. So they definitely, I encourage them that they should talk to the physicians. They could call us, more than free to call us. And then, of course, we could touch base with their physicians. And obviously, this is a physician program.
Yeah.
So it has to be driven through their primary practice.
Yeah.
So either way, we'll have to still talk to the physician office.
Okay.
And I think the hesitancy with doctors' offices was that they were going to have to pay for the equipment.
Yeah, thank you.
And explain this, how Triumph is different in this way.
There's different models, and I think there are some big, large corporate players involved too. But I think, let me talk about Triumph. The way we do is we try to do it pretty differently. So we don't necessarily have the primary practice involved or rather invest in devices. We rather do it ourselves. There are different pieces to it. There's a device involved. There's a technology, which means there's a cost for data, platform. Then, of course, we strictly use RNs just to ensure the quality of the program. And last but not the least, there is an administrative team who is looking at purely the adherency part of it. Their job is to make sure people are reminded. If they miss a reading a day, they will make sure they will reach out, remind them, and find out what's going on. So that being said, the way Triumph has structured the whole thing, we bear the entire cost. We don't try to pass it down to the practice.
Yeah,
and I'm sure there are different models.
Yeah,
Yes.
that's great.
Interesting. So outside of, I'll give you an example of like the urinary tract infection, the bladder infection that we caught. Are there other scenarios that you guys have seen that might give some ideas on, hey, mom or dad seems to be dealing with this kind of regularly? Are there things that you guys have seen where we've kind of stopped some of the transition back to the ER or to the hospital?
There has been some cases, I must say, but I think end of the day, we as a population health company focused on telemonitoring.
Yeah.
We try not to cross boundaries. So, one thing that we love to educate both the families and the patients, we are not an emergency service solution.
Yeah.
Right. If they have a fall, they get into emergency situation, then they need to do what they're supposed to do.
Yeah.
The program is designed, as I emphasized at the beginning of the call, is to bridge the gap between the patient and the doctor between the visits. But at the same time, when you are on a program like chronic care management, you have a designated nurse that you can call during the day and address your concerns. So you have that privilege under the program.
Yeah.
But just to answer your question, we're not really a solution for anything which is more of emergency in nature.
Got it. Okay. This is more looking for spotting for trends. If trends start to look differently, that's when the physician can get involved earlier on.
Okay. It's reporting to the physician.
Yeah.
Yeah. End of the day, physician drives this program. We are an extension to his team.
Yeah.
So no matter what happens, he's the first one to be informed, and he's involved, and then he takes it from there.
Got it. Okay. Fair enough.
That's great.
Okay, yeah.
If somebody wants to reach out to Triumph, how do we get in touch?
Oh, wonderful. Well, they can reach on, I don't mind taking, a call at any point in time. They could reach on 650-6170.
This has been great information, and I would love to see some statistics, and maybe we'll do a follow-up on statistics and how it really does benefit the client. And
it sounds like CMS has been doing some, because we talked before the show about, we can see some where they'll post some studies on fixing or reducing rather the return to acute. So I've seen some studies on those things, but I'm really interested on someone who looks at proactive care. I'm really looking at like, what does it look like for the year? So maybe we'll have you get back on and see if you can pull some of those and kind of discuss what that looks like, because that's where it becomes really fascinating. Because if you really can subvert that natural tendency, because someone who's older and sicker, every time they go to the hospital or have that injury or that fall, their new baseline is less and less and less and less, and so that ends up costing in terms of dollar cost, in terms of burden cost, in terms of psychological cost on the patient and the family. So if we can start to minimize some of those occurrences through something like remote patient monitoring and some of the things, I think that's a huge win.
Mm-hmm.
Absolutely. I think it's a good idea to have a follow-up call and we talk about statistics, because I think this podcast may help not just the viewers who are patients, but even doctors.
Yes.
Doctors see the benefit. Well, and I just see too how it's a team approach. And I think that's why I love your hospice so much, Angel Valley, is you really, all the team members are a part of this. But I just think about that patient who's living independently at home. The family can be involved because they know that there's peace of mind. Mom is getting her blood pressure checked every day and it's being reported.
Yep.
The caregiver that may be in the home, or let's say mom's blood pressure is up because she's not taking her medicine. So maybe we need to get home health out there and get an RN out to check her meds every week, or she just needs reminders, and maybe have somebody that comes just in the morning to help with breakfast and make sure she does her vital signs, so just stair-stepping to stay out of the hospital. Everybody wants to age in place and stay at home.
Correct.
And what better way to keep that going is to have this program. So thank you so much. This has been awesome.
Yeah. Thanks,
Thank
Girish.
you. Thank you so much for having me.